Hi guys, so I'm going to attempt to do this short video that again recaps just the highlights of today's lecture. I apologize, one dog's barking in the background. This is with the skin, hair, and nails. So I'm just going to kind of flip through my notes and pull out some of these highlights. So again, remembering that the skin is our largest organ of the body. It is our first line of barrier defense when it comes to immunity. So when we worry about the integrity of the skin, we're looking to see if there's any abnormalities, any compromise of the skin. And as we talked in the lecture today, it could be anything from a rash to bruising to an actual bed sore. Trying to think if maybe like the skin is very edematous or swollen. That could be abnormal for, we talked about like that pitting edema. So again, the very first thing when we actually go in and do that assessment portion, again, it's that specific order of inspection, palpation, percussion, and then auscultation. For you at this level, you will do inspection, palpation, and auscultation. Inspection, and upon as soon as you meet that client or as soon as you walk in that room or that patient's brought in, inspection begins. So what are we assessing? What can I see with my eyes? What can I smell with my nose? What are those abnormals versus those, or normal findings versus abnormal findings, right? And like I said, a lot of times it's going to go back to that focus assessment, problem-based assessment. So if they're coming in with difficulty breathing, you see that they look short of breath, or they look like they have that cyanosis around their lips, that's that problem, okay? Remember, cyanosis is a bluish discoloration, and we never want to see those nail beds or lips looking cyanotic. That's a problem. The definition of pallor, again, is pale, and usually that's a lack of the oxyhemoglobin. So a lot of times where we see pallor, when we look at what's called mucous membranes, and we'll talk about that more next week, but when we pull down the eyelids and look at the conjunctival sac, when you open up a patient's mouth and you look at the gums, they can look like they're pale from pallor, so people who are anemic. We talked about skin discoloration, so whether they have jaundice on the skin or they have what we call scleral jaundice or jaundice of the sclera, usually relating back to some kind of liver disease component. And then also we can have erythema, which is redness. We talked about some different dermatological issues, and again, you don't have to memorize them all, but anybody comes in with some kind of derm issue, that is a compromised skin integrity. The only thing with the dermatology that we talked about was just try to document findings in a professional tone. With the checking for dehydration, like on the patient's skin, that's called, the actual assessment is checking skin turgor, mobility and skin turgor. The finding, if the skin stays pulled up, is tinting, okay? So the assessment is mobility and turgor. The finding is tinting. We talked about how skin will change as we age, right? Skin, hair, nails, they all tint, the skin will become thinner. The hair can become more dry, more brittle. You lose body mass or muscle mass as well. The hair can lose some, again, you lose a lot of moisture from the body overall, so that's why sometimes you're going to see more of skin flaking, and you see more hair being dry to the texture, so forth. Again, with the temperature, we check the temperature with the back of the hands or the dorsum of the hands. We're always comparing symmetrical, one side to the other and one side to the other, right? You've got to have that baseline. I want to know what one side looks like before I can assess the other side, so that way if there's a deviation on one, but I got a normal on the other, then that gives me some data, okay? One of the things with the mobility and turgor that we're looking for, again, is dehydration. So again, if that person is a little younger and we don't expect to find skin tinting, then that could be, and it does tint, then that can be a sign of that patient is dehydrated for whatever reason. Okay, go back over and looking at those A, B, C, D, and E of skin lesions. And skin lesion, again, is some type of abnormal I know it doesn't have to be abnormal, but like a skin tag or a mole, um, anything like that is considered a lesion. So we're saying, yeah, moles can be normal, they can be benign, but those A through B, C, D, and E are those things that we're looking for that would indicate abnormal findings, and you need to report any new abnormal findings with skin lesions to the provider. So again, going back through where that asymmetry, borders, color, diameter, and then that evolution hasn't changed. Also, we said with lesions, another kind of key factor is wanting to know if they bleed, because that's an abnormal as well. Okay. And then when you document lesions, again too, you're going back to following descriptive measures such as location, size, color, and that ABCDE acronym that we talked about. Just kind of looking at the different lesions, and again, those were more kind of FYIs, if you will. We talk about what is ecchymosis. We said that's bruising. We know that bruising and the initial trauma, it's bleeding, hemorrhages that comes from those blood vessels underneath the skin. And that when a patient first has a fresh bruise, it generally looks like a dark purple, blue, dark. And as it heals, it will lighten up in color. A lot of times then during those healing stages, when a bruise is older, it will look more yellow or greenish. Petechiae is just small reddish little purple pinpoint lesions, and again, a lot of times it can come back to liver disease, clotting issues, drug reactions. And keep in mind too with skin, we talked about in darker skin clients, it can be sometimes hard to assess, and so you're really having to sometimes use good lighting, sometimes looking in other places for pallor or something like that. We talked about the term purpura and angioma. The other thing we said was talking about pressure ulcers, also known as bed sores, decubitus. So again, stage 1 is that you have blanchable erythema, and thing about erythema is that redness, and we talked about is it blanchable versus non-blanchable. So I will backtrack again. I'm so sorry. When I said with the stage 1, it's probably non-blanchable, but the big thing that made it different in stage 1 is that you still have intact skin. So you'll see erythema is probably not blanchable, but the skin is intact. When you come to stage 2, you can have more redness, and now you've got that top kind of layer of skin gone. Remember, they can be painful. Stage 3 now is deeper. This is where I can start seeing some of that slough, kind of like that white tissue. I can have tunneling or undermining in that. And then stage 4, again, a little deeper, and thinking about that tunneling and undermining, and why it's imperative that you do assess this thoroughly, because you want to make sure you know if your decubitus is undermining. And talked about what was some of those causative factors for people who had breakdown, and whether it was because they have fecal or urinary incontinence, they have decreased mobility, they have decreased sensation, something like that. Okay? So go back and look at that a little more in depth in your book. Again, slough is just kind of like a white, looks kind of like that whitish, kind of creamyish tissue on a pressure injury, and that is something that can be debrided so healthy tissue can grow. You can have decubituses get necrotic, or that eschar tissue, which is that black, it is dead tissue. Okay. And necrotic tissue itself really has no feeling, but again, they will generally debride that so that the patient will promote wound healing that way to get that dead tissue off. The Braden scale, again, is a nursing assessment tool that is used to assess for patients their skin breakdown risk, and generally done on everybody. It is, again, you don't have to memorize that whole scale, but you need to know what is the Braden scale, and you need to know how to use the scale. So again, it's a scoring system, and you guys can read that and review that in very pretty straightforward. Okay. All right, so we talked about alopecia versus male pattern baldness, where alopecia can happen in either male or female. It can be genetic or hereditary. It can be for menopause. It could be medication. It could be endocrine problems, and we can difference that from male pattern baldness because there's patches of hair that's missed. So you may have a patch here, just different things. My apologies, I had to take a quick call. So the alopecia and then male pattern baldness is definitely different. It's a very distinctive pattern that follows. Look at the pictures on that. Again, looking at a huge thing with that is a lot of times is that genetic component. Also, when we talk about hair, we said that if there can be issues of medications, again, thyroid or endocrine issues. Thyroid issues can make the hair very brittle, very dry. It can also cause hair loss. Thyroid issues can. Sometimes circulatory issues. If hair is excessively oily, it can be a thyroid issue or a hormonal issue. Okay, and so it's again assessing that patient to see if they've had any complaints of hair loss or anything unusual. With the pitting versus non-pitting edema, again, if you see somebody that has swelling to the lower extremities, we're knowing that that is caused from an excessive retention of fluid. And we said it could be pitting or non-pitting. So when you take your fingers, you press on that skin. If it leaves those indentation marks, that's pitting. Again, in your readings, you may see that they will grade it by like 0, 1, 2, 3, 4 plus pitting edema or whatever. You don't have to know that. You do need to recognize if it's pitting or non-pitting and just what is the causative factor of that excess fluid retention at this time. Okay? All right. I think, and then when it gets into nails, again, we would look and go, why is it nails important to look at? And again, you're not so much assessing nails on the actual physical assessment that you will perform. We look at capillary refill, but with the nails, you need to go back over the pictures that we showed and talked about in class. You got the ecchymosis, which is a fungal infection. You have got the clubbing, which looks like that club shape and that rounded shape. And that is going back from a prolonged decreased oxygenation or heart disease. You have the Bose lines, which is those vertical lines, one or multiple across the nail bed. And we're looking at that coming from some form of systemic illness. So something that can, happen all over, cause damage all over the body, systemic, or trauma to the nail bed. You'll also review the leukonychia, which is those milk spots on the fingernails or areas of white discoloration. That is nail trauma. The Terry's nails, which are the ground glass opacity kind of looking appearance with a dark border kind of towards the edge of the nail. And that too, again, is usually coming from some kind of systemic disease like diabetes, CHF, liver disease, something that has caused maybe like a decreased vascularity, as they would call it. And then also the coloonychia, which is the spoon nail. So it's that indentation kind of nail. Spoon nails look like you could put something on there and kind of, And again, that one is generally coming from anemia. All right, so I really think that's it with skin, hair, and nails. Go back just over your PowerPoint again and just focus on some of the areas that we talked about, and I think that you will be absolutely fine.